best we can do it in our babies is what we will try to learn over the next 45 minutes to 1 hour. So I want to start with some few concepts which I want all of you should be clear of. The first concept which I want you to understand is Cpap is given to newborns with respiratory distress or with babies post-extubation. Cpap cannot be given to babies who are not having any breathing effort. So they should have breathing effort for giving Cpap. Respiratory distress means tachypnea, retractions, and grunt. 2 of the 3 presents mean baby has respiratory distress. So all candidates, all babies who are having respiratory distress are eligible candidates for giving Cpap, and keep monitoring if they need Cpap if they have respiratory distress. Severity of distress is assigned by Silverman-Anderson score. This is a very simple score. I will try to touch on this during the lecture and then try to see how do we assess and when do we give Cpap based on the severity of respiratory distress. Now, for all babies with Silverman score, Anderson score more than 3, the newborn is an eligible candidate for giving Cpap. So sometimes we wait longer, but all preterms, at least if the Silverman score is more than 3, he becomes a candidate for Cpap. Earlier in the course, the Cpap is started, better is the outcome. And which if you have, Deepak has already told us, if you start in the delivery room, your outcomes are definitely much better. So can I request everybody to mute themselves? Dr. Sen, please mute yourself. Okay, so Cpap, everybody means it is pressure, continuous positive airway pressure. But Cpap has not just the pressure, it has 4 components. The pressure component is used to open the lungs and to improve the functional residual capacity. If you improve the functional residual capacity, you will improve the area of gas exchange. The lungs which are collapsed open up and your gas exchange improves. And to improve the collapsed lung to become little more dilated or distended, you use the Cpap. The second component of Cpap is you fill that alveoli with gas which is rich with oxygen. Normally atmosphere has 21% oxygen, and we want to enrich the alveoli with more oxygen when you are using Cpap. And there are 2 more components which are often ignored, but they are equally important. The third component is warming of the gases. Whatever gas we are pushing into the nose of the babies, they should be warm. When we are breathing room air, we are breathing air which is coming at 26 to 28 degrees Celsius. But when the gases are coming from the cylinders or the compressed air sources, they are coming at 4 degrees or 5 degrees Celsius. If you push this cold gas into the nostrils directly, they will lead to a lot of airway damage. So the third component of giving Cpap means warming the gases. And the fourth important component is moisture, adding moisture to the gas when you're putting Cpap to the babies. Normally, when all of us breathe room air, the room air is mostly saturated about 50%. But when we want to give Cpap, because the flow rates are higher, because these babies are breathing faster, you want to give this humidification of 100% relative humidity when the gas reaches the nose. So Cpap involves all the 4 things: pressure, oxygen, warming, and humidification of the gases. Now the pressure we measure in Cpap pressures. The oxygen which we push into the alveoli, we measure in fraction of inspired oxygen. I said room air has 21%. We try to give a maximum of 60% of air oxygen mixture when we are giving into the nostrils in Cpap. Warming of gases, the gases should reach the baby at body temperature, that is at 37 degrees Celsius, and we measure that in temperatures. Relative humidity is the way we measure the humidification of gases, and normally we want the relative humidity to be 100% when the gas is reaching the nostrils. Now, as I already told that there are 4 components of Cpap. The first component is the pressure, and the pressure range we give for babies on Cpap varies from 4 to 8 centimeters of pressure. When you're dealing with very small babies, extremely low birth weight babies, people have used pressure as high as 10 to 12, but in most of our circumstances where we use Cpap for babies, 26 or higher, we try to give Cpap of 4 to 8 centimeters. We avoid giving pressure more than 8 centimeters. Now, Deepak has already told us that what we are doing in Cpap is we are inflating the lungs. When the lungs are collapsed, when the alveoli are collapsed, the way the babies are manifest is by having recessions or retractions. So if the baby has retractions, an indirect sign that the FRC is low. To reduce the retraction, you have to increase the FRC. And how do we increase the FRC? By increasing the pressures. So babies who have retractions, baby have hypoxia, or if your lungs are low volume on the X-ray, we are looking for 6 to 8 spaces on the posterior aspect in the X-ray. If the spaces are less than 6, that means we may have to increase the pressure. If the spaces are more than 8, we may have to decrease the pressure. So if the baby has retractions, if the baby has hypoxia, or if the lung volume is less, there is a need for increasing pressure. Maybe if you start from 5, you will increase to 6. If you're on 6, you can go up to 7. If you're at 7, you go up to 8. So basically, we give pressures to inflate the lungs to increase FRC, thereby decreasing the work of breathing or decreasing the retractions. So the second component of Cpap is FiO2 or oxygen. When the baby is on Cpap, we give oxygen from 21 to 60%. How much oxygen we are giving? What we are aiming for? We are aiming for a saturation of 90 to 95 or 91 to 95%. If your saturation is less than 90%, the baby requires more oxygen or more pressure. But if the baby has more FiO2, more saturation, that is more than 95%, that means baby requires lesser FiO2. So based on the saturation, we decide whether the baby requires more oxygen or less oxygen. The third component is Cpap flow. And this you will understand from the subsequent slides. Why do we need flow? We need flow of gases across the nose. The gases should be flowing across the nose to build pressure in the circuit and to build pressure in the airway and in the lungs. So flow is mandatory across the nose for delivering pressure to the airway and to the lungs. So how do we know flow is available or not? By looking at the bubbles in the bubble chamber, otherwise by measuring the pressures while they are reaching the lungs or like reaching the noses. So one way is by looking at the pressure measurement at the nose. The other measure way in bubble Cpap is by looking at the bubbles in the bubble chamber. We know that flow is available or adequate or not. Temperature, the gases should reach the nose at 37 degrees Celsius, and how that is the body temperature. How do we know that? The humidifier should display always 37 degrees on the monitor there. Humidity should be 100% relative humidity when the gases are reaching the nose. And this moisture will help better airway maintenance, better function of the airway, better mucociliary function, lesser chance of infection, lesser airway resistance. And the gases should be reaching the nose at 100% relative humidity. How do we know about this, whether the gas is reaching at appropriate humidity or not? For that, you have to know that there should not be any water in the inspirator limb and there should be some mist in the expirator limb. So when the gas is coming to the nose, in that circuit, there should not be any condensation. But when the gas is leaving the nose out on the expirator limb, you should be able to see some moisture in the expirator limb. If that is happening, then you know that the gas is being delivered at 100% relative humidity. You can have hygrometers which measure, but clinically that is what you can look at. Now let us look how do we ensure that we get pressure, oxygen, and temperature and humidity. What do we need for getting these 5 components? So for generating pressures, we need flow of gases, we need an inspirator limb, we need an expirator limb, and we need to create an obstruction to gas flow and a leakless system. So this I will try to explain in the next slide. So to generate pressures, you need a circuit like this. Okay, so you need a circuit like this, where this is the inspirator limb, this is the expirator limb, this is the nasal interface, and this is the lung of the baby. Now the gas is flowing towards the baby in the inspirator limb. The gas is flowing in the inspirator limb and it is going across the nose of the baby. So, and if you open it to the atmosphere, the gas will leak out to the atmosphere. Now, normally what happens if you make the gas flow across the nose, This is the nasal interface. This is the lung. If the gas is flowing across the nose and it is open to the atmosphere, so this is the inspiratory limb, this is the interface, this is the expiratory limb. So if you make the gas flow across the nostrils, in fact, what will happen is it will suck the gas from the lung to the inspiratory limb and to the respiratory circuit. This happens because of a phenomenon called Bernoulli principle. When the gas is flowing across, the lateral pressures decrease and it will suck the gas into the tube. Now, if the gas is being sucked from the lungs into the tube, that is not what we want. We actually want the gas from the tube to go into the lungs, expand the lungs. So how can we do that? So if the gas is flowing across the tube, across the nostrils, and it's connected with the lung using an interface, so what we can do is we can create an obstruction. So to the gas flow, gas is flowing in the inspiratory limb. The interface is connected here. This is the expiratory limb. So if the gas is going up to the atmosphere, we create a obstruction here. By creating this obstruction, the pressure will build in the circuit. So let's say by creating this obstruction to the gas flow, the pressure in the circuit is increased by 5 centimeters. Now, since the pressure in the circuit is increased, the gas will start going to the lung till the pressure in the lung becomes 5 centimeters. Now, pressure in the circuit lung becomes 5 centimeters. So now the lung will expand from a collapsed lung or a low FRC lung to a high FRC lung. So what we have done is we have made the gas flow in a circuit. We created an obstruction, build a pressure in the tube, and because the pressure is there in the tube, the gas flows to the lungs. The gas will flow to the lungs till the pressure builds in the lungs as much as it is in the circuit. Now, once the pressure in the lung and the tube are 5 centimeter, extra gas will move out to the atmosphere. So this is how we generate a pressure. Now, what do we need to generate pressure? We need gas flows. That means you need air oxygen flowing into this inspiratory limb. You need a nasal interface connected to the lungs. You need an expiratory limb, and to this expiratory limb we need a obturator or an obstruction to generate pressure and to generate pressure in the lung and increase FRC of the lung. Now, instead of having an obstruction like this, what we can do is this tube, we put it into the, I'll just erase it once. So instead of this obstruction, what we'll do is we will put this tube into the water. Now this tube is inside water. Now the gas will flow like this. There is no obstruction here. So instead of this obstruction, I am trying to say we put the tube inside the water. Now the gas will flow into the tube. Till this level, there is no obstruction to the gas. Now from here, the bubbles have to come out. So if they have to come out, they have to go through this water column and come to the atmosphere. So instead of having obstruction like this, we have created another obstruction by putting the expiratory limb inside water. Now the resistance we created is equal to the depth of immersion of the tube from the level of water, how much this tube is inside water. That is the resistance we have created for the flow of gases. So let's say this is 5 centimeters. So now this is 5 centimeter resistance is created because this column has to move 5 centimeter from the bottom till the water level. Now since you created this 5 centimeter resistance, the gas in the circuit will leak to the atmosphere only when the pressure in the tube is more than 5 centimeters. So maybe when it is more than 5.1, the gas will leak out to the atmosphere. Since we created obstruction to the gas flow, we created pressure in the tube and gas will flow to the lungs till the pressure in the lungs become 5. and then now the excess gas will leak out to the atmosphere. So if the bubbles are there in the bubble chamber, or the bubbles are bubbling out in the bubble chamber, which means that we have that pressure, whatever is the resistance created here, that much resistance is there in the tube and that much resistance is there in the lungs. So bubbling is an indicator that whatever resistance you have created in the bubble chamber, that is present in the circuit. And if you are able to hear the bubble sounds in the chest, that much pressure also is there in the lungs. Now, if you want to increase the pressure in the circuit or in the lungs, what we do is we push this little more inside. From 5 centimeter, let us put this inside 6 centimeters. Now the gas has to bubble out from the zero level or the lower level till it comes to the water column level. Now this has become 6 centimeters. Since it is 6 centimeters, the pressure in the tube has to become 6. The pressure in the lungs has to become 6 when the gas wants to bubble out to the atmosphere. So to ensure that the pressure is there in the tube and pressure is there in the lung, we can push this inside, or to decrease the pressure, we can push this tube, pull this tube out, so that the pressure in the tube and the pressure in the circuit and the lungs decreases. So this is how we generate pressure when you're using bubble CPAP. So the concept is very clear. To generate pressure, we need an inspirator limb, we need an expirator limb, we need a nasal interface, and we need to have an obstruction, and that obstruction we are creating with bubble water or bubble chamber. So for generating pressure, we need flow of gases, we need a leakless system, and an obstruction with a bubble chamber or with a valve like this, which is there in the ventilators. So for generating FiO2 from 21 to 100%, how do we get the FiO2 from 21 to 60%? What we use in the ventilators. For that, you need a compressed air source like this, compressed oxygen source, and a blender. So you need air, oxygen, and a blender to ensure that we get the FiO2 from 21 to 60%. So compressed airs, compressed oxygen, and a blender are needed for you to give oxygen from 21 to 60% into the lung. So for generating pressure, we need flow of gases and obstruction. For giving FiO2 or oxygen from 21 to 60%, you need compressed air source, compressed oxygen source, and a blender. Now, what do we need for temperature and humidity? Luckily, we need only one device, that is a humidifier. But this servo humidifier should be in such a way that it displays 37 here, and it has a heating element inside the inspirator limb. The gas will continue to get heated till it reaches the nose of the baby. So there is a heating element which is present in the inspirator limb, which is maintaining the gas temperature till it reaches the nose, so that the gas reaches the nostrils at 37 degrees Celsius. So a servo humidifier is what gives you temperature and humidity. So the 4 components of CPAP: pressure, oxygen, temperature, and humidity. Temperature and humidity we are achieving with servo humidifier. Oxygen we are achieving using compressed air source, compressed oxygen source, and a blender. And pressure we are able to achieve with flow of gases and circuit and obstruction to the flow, and a nasal interface, a leakless system. Now this is what you have to understand as far as the CPAP practical application is concerned. Now let us look practically how do we do CPAP for a baby. Now, clinical application, we look at a case-based discussion here. When to use what non-invasive ventilation, what are our choices, how do we monitor our babies, how can we improve the efficacy, and what are the learning options. If after this workshop you still want to learn, are there any options, is what we look at it. So I'm going through this case scenario. This is a 28-weeker, 1 kg baby, female child, born of preterm labor. 1 dose of steroid was given 6 hours delivery. We all know the importance of antenatal steroids. The baby was born by C-section. There was no asphyxia. Baby had respiratory distress from birth. So since he is a preterm, almost like extremely low birth weight, started having respiratory distress at birth, he was planned to shift to a NICU, tertiary care. And for shifting, he was shifted on nasal oxygen after 4 hours of travel of 100 kilometers from a district. At admission, the baby had temperature of 36. Baby had severe respiratory distress, and Silverman-Anderson score was 7/10. And SpO2 on nasal oxygen was 93%. Now, once somebody can ask me that this baby is already maintaining saturations, so why do we give CPAP for this baby? So any baby with respiratory distress is a candidate for CPAP if his Silverman score is more than 3, especially if it's preterm baby. But if it's a term or a late preterm baby, if your Silverman score is more than 5, he is a candidate for CPAP, irrespective of the saturation limits. So he is struggling to maintain that saturation. So you want to decrease his struggle, and you can only decrease his work of breathing or the struggle by giving CPAP. So this is the baby here. I hope all of you can see this baby here.
Yes, sir.
Okay. So this is the baby here. Baby is having nasal flaring, grunt, and you can see the upper chest. Upper chest is mid-axillary line. The abdomen is going up. The chest is caving inside. There is some sternal retraction, and you can see the retractions on the posterior aspect, that is below the mid-axillary line. So nasal flaring, grunting, some sternal retractions, abdomen going up, chest coming down, and intercostal retraction below the mid-axillary line. So this is what this baby has. Now let us look at what is the score of Silverman which this baby has. Now looking at the score in the upper chest, over the mid-axillary line, look at the chest and abdomen. In this baby, the chest, abdomen was moving up, the chest was going inside. So this score for this baby is 1. If it's a seesaw type of thing, the score becomes 2, but this baby score is 1. Now looking at the lower chest, that is below the mid-axillary line, the retractions. Yes, this baby had retractions, but not reaching up to the axilla. So the score for lower chest is also 1. Baby had some xiphoid retraction, so that also is 1. So no retractions is 0. Some retraction sternal is 1, and severe retractions is 2. And nasal flaring, this baby had significant nasal flaring. You could see on the video from a distance. So this becomes a score of 2. Expiratory grunt, yes, the baby is having grunting. So the score is 2. So 2 score for grunt, 2 score for nasal flaring, 1 score for xiphoid, 1 score for lower chest, 1 chest score for upper chest. So baby had a total score of 7, and it's a 28-weeker. So this baby, irrespective of the saturation, is a baby for non-invasive respiratory support. Okay, and this is the X-ray of the baby. You can see that this X-ray was done after starting the baby on a non-invasive respiratory support, but you can see the reticular granularity, there is air bronchogram, and the spaces are 7 spaces. This is all while the baby is on CPAP. So, but if you have a baby like this coming at 4 hours who has a Silverman score of more than 7, what respiratory support you start in this baby, how do we give that support, and what do we monitor for is what we'll look at now. So what respiratory support in this baby? This is a preterm baby less than 35 weeks. Your score is more than 3. So this is a candidate for CPAP or non-invasive respiratory support. When we give support like this, it is called primary respiratory support, support for primary respiratory distress. This baby is just born, having distress and giving respiratory support. This becomes primary respiratory distress support. So what support we can give? Either CPAP or nasal IMV. Between these two, I prefer CPAP, and Deepak has already told me that CPAP is the best, bubble CPAP is the best CPAP. So I will prefer bubble CPAP, but there are some units who want to do ventilator CPAP or a flow driver CPAP. Your choice is, you have a choice. But if your unit has enough capacity to do nasal IMV, and some units want to do nasal IMV, but it's more costlier, it requires more intervention and more monitoring. So one would prefer CPAP over nasal IMV. But evidence-wise, if you ask me, maybe there is little more advantage in nasal IMV compared to bubble CPAP. But since bubble CPAP is cost-effective, I would prefer bubble CPAP for this baby. And what interface? Choice is yours. You have multiple choice of interface, Hudson prong, or Ram's cannula, or nasal mask. So any one of the interface you will start for this baby. So this baby, no doubt, requires CPAP, and we'll start CPAP for this baby. So as I told you, the choices are 3 type of CPAP machines. This is a Hfnc bubble CPAP machine. This is another bubble CPAP machine, and this is a ventilator CPAP. All these are equivalent, but since it is more cost effective, we want to use bubble CPAP. And the interfaces, you can choose any one of the 3 interfaces, either Hudson prongs or Drager mask or Ram's cannula CPAP. So one of the 3 choices you have, and whatever choice you are using, continue to use it long so that your experience improves and your nasal injuries come down. So, but you have choices of CPAP machine and you have choice of interface. But our choice is, yes, we'll start CPAP for this baby. So how do we set up? Now, once you know that this baby requires CPAP, I will show you how to set up the CPAP in the video. So these are some of the videos which are readily available on the YouTube. So Akash, can you see the video?
No, sir, not yet.
Not yet. Okay, I'll resume share. Can you see now?
Voice only is coming, sir. Not
I'll show.
video is not.
Now?
Now screen is being shared.
Circuit.
Started, sir.
Yes.
Machine.
So you have decided
Gloves,
to start CPAP.
Yes, sir.
Distilled
You have
water.
all this.
Clean the machine with 2% Sidex or any other approved disinfectant. Clean the heater wire and temperature probe with a clean and soft cloth and sterilium. Connect the machine to compressed source of air and oxygen. After washing hands and wearing clean gloves, open the disposable CPAP circuit. Fix the water chamber onto the servo humidifier and fill it with distilled water. Use the autofill option of fixing the distilled water bottle to a stand for filling the water chamber. Fill the bubble chamber with clean or distilled water and fix it to a slot available on the CPAP machine stand. Now fit the safety device between the flow meter and the water chamber of humidifier using the green gas tubing. Now connect the blue inspiratory limb to the other port of the water chamber. To the other end of the blue inspirator limb, lock the white expiratory limb of the bubble CPAP circuit. The second end of the expiratory limb is connected to the bubble chamber. Fix the heater wire and the temperature probe to the appropriate slots available in the humidifier and the inspiratory limb of the bubble CPAP circuit. Switch on the humidifier and set in invasive mode as shown here. Watch for bubbling in the bubble chamber. Set the FiO2 flow and pressure to appropriate level. Wait for the humidifier to display a temperature of 37 before connecting the circuit to the patient.
So we have decided to start CPAP for this baby, and so we have seen how to start the bubble CPAP. Now next is how do we, so in fact you should be ready with the bubble CPAP even before the baby comes. So if somebody tells you that some baby is coming to you, you should be ready to keep the CPAP machine ready and the temperature should be displayed 37 before you connect it to the baby. Now once the CPAP is there, you need to connect an interface, and let's look how to connect an interface on the baby in another video. These are very
In
important
this video,
steps.
we shall learn the fixation of binasal prongs for the delivery of CPAP to a newborn. Assemble the Hfnc prongs of appropriate size, gloves, green sheet, scissors, rubber bands, safety pins, tegaderm, and few connectors. Find the Hfnc prongs, velcro, and connectors in the prongs kit. Cut a strip of tegaderm. Open the velcro. Cut the soft velcro which is to be fixed on the prongs. Cut the rough velcro of appropriate shape which will form the base on the philtrum. Fit the soft velcro onto the prongs on either sides of the prongs. Close the pressure pot on the prongs with a sterile cap. Fix the connectors to the prongs. Now fix the cap to the head of the baby, ensuring that the ears are properly covered. Fix the tegaderm and the rough velcro on the philtrum to form a base as shown in the video. Insert the nasal prongs into the nostrils and fix them to the base. The soft velcro on the prongs locks with the rough velcro on the philtrum. Connect the limbs of the circuit to the ends of the nasal prongs. Now fix the connectors to the cap on either side using the safety pins and the rubber bands. The rubber bands are made in a figure of 8 for fixing the connectors onto the cap. Now give support to the tubings by placing a green sheet under them. Insert an orogastric tube and fix the end of the tube to the side wall of the incubator. Keep the end of the orogastric tube open. Now watch through the gas flow for any leaks in the circuit. Set flow and FiO2. Water in the humidifier chamber. Temperature on the humidifier. The heater wire and heater wire probes. Ensure that there is some distance between the prong and columella. The expiratory limb inserting into the bubble chamber. Watch for the bubbling and water level, and also check for the set pressure in the bubble chamber.
Okay, so we have learned now how to, this baby requires CPAP. We have decided on that. Now let's also, we know that this baby is going to be started on bubble CPAP with a Hfnc interface. But I said choice is yours. You have many more choices. But this baby we are going to start on bubble CPAP with a Hfnc prong interface. Now how do we set the knobs and adjust the parameters? Since this baby has respiratory distress, we are going to start the baby on Cpap with some FiO2 and a flow rate. Normally when the baby has a respiratory distress, we start with a Cpap pressure of 5 centimeters, FiO2 of 30% and a flow rate of 5 liters per minute. Remember the rule of 5 pressure and 5 flow raters. FiO2 we used to start with 50, but now we realize that 50 is very high. Starting with 30% FiO2 is quite sufficient for most babies with respiratory distress. Now once you do this, how do we adjust? So immediately after starting the baby on bubble CPAP, look for bubbling. If bubbling is there, means your flow rate is adequate. No need to change the flow rate. But if your flow rate is 5 liters, if there is no bubbling, keep increasing the bubble flow rate from 5 to 6 or 6 to 7. But even with 7, there is no flow rate, there is no bubbling in the bubble chamber. Definitely there is some leak in the circuit. You have to take care of the leak in somewhere in the circuit or interface, or baby is crying and mouth of the baby is open. And if the mouth of the baby is open, then you have to calm the baby rather than putting pacifier or closing the chin of the baby. So first is C for flow rate adequacy. Then look at saturations. If your saturations are between 90 to 95%, then your FiO2 is adequate. Now the third thing you have to see is whether your pressure is adequate or not. We started with a Silverman score of 7/10. Immediately after starting the baby on Cpap, the grunt disappeared. So if the grunt has disappeared from 7, the score has automatically come to 5. That means baby has started showing improvement. So wait for about 15-20 minutes for the retractions to come down further and to see that whether your pressure is working or not. So if there is a downfall of Silverman score, or if the decrease in Silverman score, your pressure of Cpap is working. So how do we adjust the Cpap? So if there are retractions, or if the Silverman score is same or worsening, then you increase the pressure. If you do a chest X-ray after 15 to 30 minutes, if the X-ray is showing less than 6 paces still, then you have to increase the pressure. Or baby is having retractions and saturations are less than 90%, then you have to increase the pressure. So for the FiO2, you have to think that your saturation should be between 90 to 95%. When do we increase the FiO2? When do we increase the pressure? This is very simple. Suppose baby has saturation less than 90% and baby has retractions, then you increase the pressure. If baby has saturation less than 90%, retractions have come down, your Silverman score has come down, don't increase the pressure, increase the FiO2. So in the presence of retractions, our aim is to increase the FRC. And if FRC already is increased, the retractions have come down, then you increase the oxygen going to the lung by increasing the FiO2. So whenever there is desaturation or less than 90% saturation, if retractions are there, we'll increase the pressure. If retractions are not there or minimal or decreasing retractions, we'll increase the FiO2. And flow rate, I've already told you, look at the bubbles in the bubble chamber. So saturation less than 90% with retractions, increase the Cpap. If saturation are less than 90% with improved retractions or no retractions or minimal retractions, increase the FiO2. On the contrary, if the saturations are more than 95%, that means your saturation is good and you are not having any retractions. That means your pressure is good and you are giving more oxygen, you have to decrease the FiO2. But when you are decreasing the FiO2, when there are no retractions, you are able to decrease the FiO2. For every 10% reduction in the FiO2, try to see if you can come down on the pressure. Suppose you're in a pressure of 7, your FiO2 drop down from 60 to 50%, then you have to decrease your pressure from 7 to 6. While increasing, you will increase the pressure to decrease retractions and improve saturation. So from 5, you will go to 6, 6 to 7, till your retractions come down. And if retractions are still not come down, then you can go up from 6, 7 to 8 also. But while you're increasing pressure, the desaturations of the saturations are still low, retractions have decreased. Say on pressure of 7, retractions have come down, but saturations are still low. You increase the FiO2. So while going up, we'll increase the pressure and then increase the FiO2. Now, once the baby is stable, no retractions, saturations are well maintained above 95 or 94%. First thing is come down on the FiO2. Whenever you are able to come down on the FiO2 by 10%, try to see if you can come down on the pressure by 1 point. So the infant was started on bubble Cpap with binasal prongs with a pressure of 5 centimeters, FiO2 30%, flow rate of 5 liters per minute, and the X-ray was done. Since the X-ray was showing RDS, what these people have done is, since the baby is requiring Cpap, it's a preterm baby, apart from giving Cpap, they give Ensure. So one method is increasing pressure, the other method is adding surfactant. So early surfactant with early Cpap will help in improving the outcome of Cpap babies. So this baby was given surfactant along with Cpap, and over the next 1 hour, the baby's retractions reduced. So SA score came to 4 by 10, FiO2 was 30%, flow was 5 liters per minute. And over the next 12 hours, you can see here, the baby's retractions almost disappeared. And so they could decrease the FiO2 from 30% to 25%, and the flow was maintained on 5 liters per minute. Now, what do we do now? Now we know there are no retractions, FiO2 is low. Now we can decrease the pressure from 5 to 4. So once you come to 4 pressure and FiO2 25%, this baby need not be on Cpap. So what do we do next now? So if the baby is more than 1 kg, we can start this baby on Hfnc. But if the baby is less than 1 kg, some of these babies you may have to continue to keep the baby on a pressure of 4, FiO2 as low as 25%. Till the FiO2 comes to 25%, you might have to keep these babies on Cpap. Less than 1 kg, we may continue on low pressure Cpap till FiO2 comes to 25%, 21%. Babies, bigger babies, we can switch over to Hfnc. And how do we start Hfnc? What do we do with Hfnc? I think Dr. Shalini will discuss with us. So whenever you're going for Cpap to Hfnc, we maintain the same flow and FiO2 21% or up to 25%. when the baby is shifted from Cpap to Hfnc. And Hfnc is when the flow rate of gas is from 2 to 5 liters or more than 5 liters, we call it as Hfnc. Any gas flow more than 2 liters, we call it as Hfnc. So this baby, we started on Cpap, we gave surfactant, retractions reduced, so we decreased the FiO2 first, then we decreased the pressure. When we came to a pressure of 4, FiO2 21% or 25%, we switched this baby to Hfnc. Now the same baby, let's assume a different scenario. The infant was started on bubble Cpap with binasal prongs with a pressure of 5, FiO2 30%, flow rate of 5 liters per minute. And since the X-ray was showing RDS, Ensure was done. But over the next 3 hours, what happened? The score remained still 7/10. There was no decrease in the retractions. Baby continued to have grunting on Cpap. Baby continued to have nasal flaring. Retractions have actually worsened. So the pressures were gradually increased from 5 to 6, 6 to 7. But still there was not much change in the retractions. And saturations were low. So FiO2 also was increased from 30 to 35 and gradually legged up to 60%. So since the baby was having retractions and low saturations, initially pressure was increased and FiO2 was increased to 60%, but flow remained 5 because their bubbles was seen in the bubble chamber. And once you came to 7 pressure and FiO2 to 60%, the retractions now came down to 5/10. So Silverman score decreased, the grunt disappeared, but other parameters remained the same. So the baby was in Cpap 7 centimeters with FiO2 60%, flow of 5 liters. So what is the plan now? So he is on the maximum settings. He still has moderate retractions. So should we allow this baby to continue on Cpap, or what should we do now?
Ventilator.
Okay, so most people think it is ventilator, but before you start ventilation, you have to see whether you have given adequate Cpap for this baby. All the 4 components, pressure, FiO2, temperature, humidity, have you been able to establish that to the nose and to the lungs of the baby? How do we know that? So if there are no leaks in the circuit, so bubbling should be good. If bubbles are good in the bubble chamber, definitely leaks are not there. Now you should be able to hear the bubbles in the chest. Then only you know that the air is reaching the lungs. Otherwise, the air is going across the lungs, but there is a block in the nose. That is why you are able to see the bubbles in the bubble chamber, but you are not hearing the bubble sounds in the chest. So you should be able to hear the bubble sounds. There should not be bubbles in the bubble chamber. Humidification appropriate, which means humidification appropriate, which means there should not be any condensation in the inspirate limb. There should be some moisture in the expirate limb. Nasal interface, the seal should be appropriate. You should have used the snugly fitting prongs into the nose. Baby should not be troubled. They should not be crying with pain. So there should be gap between the columella and the nostrils and the interface. And chest X-ray, you repeat. If it is showing 7 spaces, still reticular granularity is still there. There is no pneumothorax. And 2D echo was done at this time. There is showing PPHN and TRJ of 40 and a moderate pulmonary hypertension is there. So what do we do now? So again, 2 approaches. I would prefer to give another dose of surfactant and continue to the baby on Cpap. The second approach is, okay, since the baby is already on maximum settings and still not maintaining saturation, still has significant retractions, then we can go to nasal IMV or invasive mode of ventilation. So we have 3 approaches. One is continue by giving a second dose of surfactant. Second approach is, but before giving surfactant, we have to ensure that all the parameters of Cpap is adequately given for the baby. If that is done, surfactant second choice. If surfactant you are not interested, then you go to nasal IMV. And if you don't have nasal IMV facility, then you go to IMV. So in that order, we can go. So the second baby, this baby was given second dose of surfactant and continued on Cpap and PPHN was managed by correcting hypoglycemia, hypocalcemia, anemia, polycythemia and acidosis. He was started on inotropes, a fluid bolus was given, and pain relief was done by nesting him, by comforting him, by putting mother's milk into the mouth of the baby, and by ensuring that the orogastric tube is above the level of the tummy. But in spite of all this, the baby continued to desaturate and continued to have retractions. At this point of time, it was declared that baby has failed Cpap. He required pressure of 8, FiO2 60%, still desaturations, and saturations are still 90%, and all 2 doses of surfactant already given. We are on maximum pressure of 8, FiO2 60%. Still baby is not maintaining saturation, still has retraction. That means the baby requires more support than Cpap. At this point of time, the decision was either to start nasal IMV or ventilation. So When you do this, it is called rescue mode of support. Nasal IMV is used as a rescue mode of support for failed Cpap. This is the current indication. So although some people use Cpap, nasal IMV as a primary mode, but we often use it for a rescue or a failed Cpap. We use nasal IMV. The settings of nasal IMV are same as that you do on the ventilator. The interface can be the same Hudson prongs. Instead of the bubble Cpap machine, you connect it to the ventilator. And you continue with the same Cpap pressure of 5 or 6 on the PEEP. PEEP pressure is what is added. TI is what it added. You add rate to the ventilator and you can add high flows on the ventilator, and you continue with the same FiO2 when you start the baby on ventilator. So on the ventilator, you need to watch for retractions. If retractions are still there, you may have to increase the PEEP or Cpap on ventilator. And for chest rise, you look at the PEEP, and for FiO2 saturations, for adjusting FiO2, look at the saturations again. So the summary of NIV management is Cpap is a primary respiratory support as we seen in this baby. It is used for respiratory distress as seen in this baby, but it can also be used for recurrent apneas and post-extubation. When you're starting for recurrent apneas, you use a pressure of 4, FiO2 as low as 21% to 25%. Post-extubation, when you start Cpap, you use a pressure of 5, and FiO2, whatever you have extubated from ventilator, same FiO2 will continue on Cpap. Nasal IMV facilities exist. It can be started as same time as that of Cpap. Otherwise, it should be used as a rescue mode for failed Cpap. Hfnc, we have seen, and this is case, if the baby is more than 1 kg, baby is on a pressure of Cpap 4 and FiO2 25 or less than 30%, we can switch over to Hfnc. Otherwise, it can be a post-extubation alternative to Cpap or a nasal IMV for babies more than 1 kg. How do we increase the efficacy? 5 more minutes, I'll finish off. How do we increase the efficacy of nasal IMV or nasal all Cpap or Hfnc? For this, you have to remember that your mask, your interface should be appropriate. Whether you use mask or Ram's cannula or Hudson prong, you continue to use it. Learn the intricacies of using the interface so that your nasal injury will decrease. Expertise is the best method of decreasing nasal injury with any interface. Bubble Cpap machine, yes, if you're using a machine, any Cpap machine, you need compressed air source, compressed oxygen source, blender, and a servo humidifier. I told you why required all this. Ensure appropriate humidification. The gas should reach the nose at 37, and there should be 100% relative humidity when the gas is reaching the nose. And we should monitor the baby, the interface, and the machine if you have to ensure adequacy of Cpap. Simplify the settings. Start with a Cpap of 5. The baby has respiratory distress, flow of 5, and FiO2 titrate to maintain the saturation between 91 to 95%. You can start with 30% and keep on increasing till you get the saturation of 91 to 95%. So always know to troubleshoot and use of adjuvant therapies such like surfactant, feeding, caffeine as early as possible so that the babies remain comfortable on Cpap. And always have some backup ventilation when you're looking for babies who are extremely small, or when you have to give 1 dose of surfactant, still baby is not improving. Then think of referring to a place or try to think of ventilation. So as I said, any one of the 3 choices are good: Hudson prongs, mask, Ram's cannula. Ram's cannula is mostly used for babies more than 1 kg. And when you're using Ram's cannula for Cpap, it should be snugly fitting. You can use a duoderm or for fixing, and this should be complete seal should be there. But when you use Ram's cannula, never close the mouth of the baby. Don't use pacifier or close the mouth of the baby or use a chin strap. Never use chin strap. You should use complete nostril closed with Ram's cannula, but mouth is open. Otherwise, there is no vent of air, and it can cause very bad problems of pneumothorax if you close the mouth also. So snugly fitting Ram's cannula is as good as other interfaces for both Cpap and nasal IMV. So as far as Cpap machine, compressed air, compressed oxygen, blender, a good humidifier, and a good pressure source like bubble Cpap, or in flow drivers, the pressure source is the interface as you can see here. So for humidification, ensure there is no condensation in the inspiratory limb, that is the blue tube should never have water, and there should be some mist in the expiratory limb or the white tube. And if possible, try to keep the baby on the mother's tummy as long as possible, because this will help in giving the best care for the baby along with Cpap. So for monitoring, you need to monitor the baby, heart rate, respiratory rate, capillary refill time, Silverman score, breath sounds or bubble sounds, urine output, girth, Cpap pressure, and FiO2. And based on this, we can see whether you need to increase the pressure or increase the FiO2. And as far the patient end is concerned of the machine or the interface, look at the cannula distance between the interface and the columella. Look at the nasal nose frequently to see any redness is there. Look for columella excretion. Do at least one suction every shift. Ensure that the orogastric tube is in situ. And in the machine end, bubbles should be present in the bubble chamber. Temperature should always be displayed on the humidifier. The tubing of the nasal, the inspirator and expiratory circuit should be below the level of the baby, and the flow rate should be 5 liters per minute, maximum up to 7 liters. So this is simplified chart which I have provided to you on the WhatsApp. All of you can use this chart in your unit to ensure that all the nurses are aware how to do the appropriate CPAP. So the last slide, if there are retractions and if the desaturation is there, that means your gas is not going to the lungs. So the reasons could be you are not giving adequate pressure or there is a leak in the circuit. So retractions means the FRC is inadequate. If FRC is inadequate, either your flows are inadequate or your pressures are not there, or there is a leak in the circuit, or there is a block in the nose. If saturations are low but retractions are not there, air entry is good, bubble sounds are heard, then that means there is a problem in the blender, or you are giving it less oxygen, or like it could be a case of PPHN. If there are desaturations and severe retractions, air entry is poor and no bubbling, that means leak is there in the circuit. There is condensation in the inspirator limb, your heater wire is not working, room temperature is too low, all the distal part of the circuit is under the radiant warmer. If there is no condensation in the expiratory limb, that means your humidifier chamber is not working. So last slide, to learn CPAP or to learn entire neonatology, you have this wonderful preterm package. This you can look at Google, preterm care, eliminatingrop.com. You can learn CPAP and almost all neonatology you can learn, and you can teach your nurses in a simplified language by looking at this. Or you can look at the YouTube videos which are available in my channel, or you can buy a book from Noble. CPAP module books are available, or you can attend a CPAP workshop like what we are doing today, or spend some time in some of the units which you do regular CPAP. Thank you.